At 3 a.m., suddenly you feel that crushing pain while you're
Ouch.
asleep and you're bewildered. What is happening? Why is this happening to me? What is wrong? Is it my heart? Is it my esophagus? What is it exactly? Or have I been hit by somebody sleeping next to me? You immediately rush to the emergency room and they tell you that you have a change in the ECG. You have an ST elevation. You're immediately rushed to the cath lab and they do a catheterization and nothing is there. Your coronaries are totally fine. So what is it that you need to know about this condition and why does it happen, how to manage it, and follow up? So for starters, this is what we call a vasospastic angina. You don't have a plaque in your coronaries. No, it is not related to exertion. It is not a demand ischemia wherein your heart needs more blood flow in relation to what's happening inside the coronaries. When you exert yourself, you need more blood flow to the heart as well as the body. In those instances, this doesn't happen. However, with a heart attack, you usually have a demand ischemia. So just think of it like this. You have a healthy pipe and suddenly it squeezes. Now, this condition is generally underdiagnosed because most people want to find a reason as to why it's happening. Some patients do not have that long-term capabilities to be patient with the doctors to figure out what the diagnosis is. So for the general epidemiology of it, you have younger patients are at higher risk, usually patients who are smokers, patients who are taking illegal or illicit drugs, and people from the East Asian populations. Now, this condition usually coexists with normal coronaries and at certain instances mild atherosclerosis. So you'll be seeing those in patients between the ages of 20 and 40 where their coronaries are relatively clean. So make sure next time you see a patient who's young complaining of chest pain that this is something that might be serious. And do not rule out atherosclerosis unless you see it properly. Now, coming to the signs and symptoms of this condition, what usually happens is that you have chest pain at rest, either happening in the morning or at night. The episodes usually last for a couple of minutes and they're relatively very good at responding to nitrates. So if they keep on you a nitrodermal patch around your chest area and that relieves the pain, then you might want to suspect that condition. There are other conditions that might cause the same symptoms and are relieved by nitrates, such as esophageal spasms. So make sure you rule that out also. The episodes generally last for a couple of minutes and you will most probably see it early morning or at night. Now, the symptoms usually happen retrosternal. This is the sternum here right in the middle, and this happens behind it, so we call it a retrosternal chest pain. You have tightness, radiation to the jaw. These are symptoms of a heart attack. However, they are not a heart attack. It's a transient kind of condition of a heart attack. And in very rare cases, you might have syncope. Now, the ECG might be totally normal if you're not doing it right when the patient has pain, and can be abnormal with ST elevation, which is usually diagnostic for a STEMI, ST elevation myocardial ischemia, infarction, sorry. However, in those cases, it might be normal or you might have ST elevation. And just to make sure, you as doctors or as people who are watching, the ST elevation doesn't always mean that it's a heart attack. It might be a vasospastic angina, such as in this condition. Now let us take another example. Let's say you have a 40-year-old male. He's not diabetic, not hypertensive. However, he's a smoker. He has chest pain at around 4 a.m. in the morning. He's rushed to the emergency room where an ECG is done and he has an ST elevation. They send him to the cath lab, an angiogram is done, and all is within normal. He's sent home. 2 weeks later, they call you that the patient has collapsed and is pronounced dead. What happened is that the patient might have went into arrhythmia after a vasospastic angina has been missed. And that is a legit concern. Both. You might go into a lawsuit, and the second thing is that you missed the most important thing, and that is the patient has not been catered to properly. So do the investigations. Do not take any chest pain lightly. It might be a musculoskeletal symptom, however, you should never ever neglect the fact that the heart might be involved. Now, for the pathophysiology of this condition, you will have to know the following. It usually happens due to the endothelial dysfunction. And I'll be attaching a photo right here. If you can see, this is the endothelium, and you have a hyperreactive smooth muscle. These are usually the contributing pathophysiological conditions and prerequisites for vasospastic angina. As a person who's diagnosed with vasospastic angina, you might want to know the triggers that can lead to this. So number one, you have smoking. So you want to try to taper that down until you quit, because that will help your condition long term. The second thing is cold exposure. For those of you that are living in very cold areas, you might want to consider that as a risk factor. And emotional stress. Now, if you've recently, let's say, gotten married, or you've got a new promotion and you feel that stress coming out to you, then this might be a contributing factor. You might also have magnesium deficiency. So make sure you get those tested at a proper lab in your hospital, and make sure you contact your doctor. Do not get overdosed with magnesium, nor have a magnesium deficiency, because this is relatively important. Hyperventilation, wherein you take very deep breaths, and they're usually not shallow, however, they're really fast. And for the people who usually on illicit drugs without people knowing, such as amphetamines or cocaine, then you might want to consider seeking therapy to help you quit those habits. So simplifying this, the artery overreacts, which is basically the coronary artery, the arteries that are overlaying the heart. Yes, the heart supplies its own self, it supplies its own tissue, and in those instances, it's the coronaries. You have the artery overreacts, a spasm develops, ischemia happens, and you develop that chest pain. Now for the testing and the diagnosis. This is the most important part, because these will help the patient feel relieved about his condition. You know, when you don't know what's happening, you usually feel fear. However, when you start to tackle that and try to figure out what it is, the fear slightly dissipates. For starters, start with a basic EKG. Look for ST elevation during pain. If you cannot find that, then just proceed with the normal ECG. After that, proceed to an echocardiogram, wherein they do a TEE, thoracic TTE, echocardiograph, which is the normal echo. After that, you might want to consider the risk of the patient. Is the patient in intermediate risk or high risk? Does he have a family history of cardiac disease or not? If you have a suspicion of that, you might want to go for a CT coronary, wherein you'll apply contrast into the arms, and that will go to the heart, and you'll take specific pictures with the CT scan, and that will help you identify if there is a blockage or not. Now, in vasospastic, that might be quite difficult to get, because at times during that examination, the artery might not be collapsed or in spasm, so you might get a negative test. However, if you develop a spasm during that time, then it will be there. However, during this procedure, they also administer nitrates into your mouth, and that might help with the dilation. The second thing is that, the next step you want to consider is doing a coronary angio. If that is all negative and you have a high suspicion of that happening, then you go for a catheterization, wherein you insert a stent, usually through the radial artery on either your right or left side of the hand. And if those fail, you might want to go for a femoral access, where that is in the lower regions next to the pubes. You go and you see if there's a spasm. Now, you'll only be able to diagnose that if the spasm happens at the moment of the catheterization. And in certain instances, what you can do is do a provocative testing, and acetylcholine or ergonovine testing, and those should be in a monitored and controlled environment. The most important thing is that for the differentials, you have to rule out other conditions such as acute chest syndrome, pericarditis, Takotsubo, and pulmonary embolism. Normal coronaries do not mean that the patient has a benign disease. As I've given in the previous example, vasospastic angina can potentially lead to a ventricular arrhythmia, which is quite deadly. Now, for the management, usually you'll be started on calcium channel blockers such as diltiazem or amlodipine, or in certain instances, they might also consider verapamil if you're having any anatomical abnormalities in your heart. And if those fail, you might want to increase another medication. So if you're taking 2.5 mg of amlodipine, they'll make it into 5, and they potentially might add a long-acting nitrate such as Imdior. And you have to know one thing, that certain medications, even if advised by family members, should be at all times avoided, such as beta blockers. Patients who are taking Concor or metoprolol, you might have the idea that those might be helpful, however, they're not. So make sure of that. Now, after you've done all of this and you feel better, of course, they'll give you follow-ups, and you'll be following up in the clinic potentially at around 1 month. However, make sure that you avoid the common stressing factors, the things that contribute to it. The risk factors should be avoided at all costs. Now, I know some people might not find it easy, such as if they're in a stressful environment. However, you want to manage those things. If you can get lighter duties, if you can have better work environments, you might want to consider that. Then you will have ECG follow-ups. You also want vitals being checked. If you feel any symptoms after taking the medication, such as hypotension or lightheadedness, then you might want to visit your healthcare center. And rest assured that within the first week of starting nitrates, you might suffer that. And in certain instances, and most instances actually, we recommend taking nitrates in the morning. Why? Because it has a long-acting duration and it will not have that washout period at night. So make sure you take it in the morning between 7 and 9 a.m. What is the prognosis of this condition? You will be on calcium channel blockers and might be titrated with time. Your symptoms should be monitored closely. You should document any abnormalities. If you have new onset palpitations or those, make sure you inform your covering doctor. The prognosis overall is excellent, however, can be dangerous. Take your medications, follow up, and you'll have an excellent prognosis. You don't do those things, your prognosis might not be as good as that.